Okay, madam is.
So we are going live, sir, and we are ready to go.
Fine.
Good evening, everyone. I am Batul from Clearnet. I would like to take a minute to introduce our platform Clearnet to everyone present here with us today. Clearnet is India's one of the largest digital live CME platform where doctors generate their medical content. I would like to welcome all the speaker doctors and the participant doctors in today's live digital webinar that is organized by Academy of Paediatrics Gujarat eGurukul PG Clinic. Team Clearnet is happy and proud to be the digital partner for this webinar. Please have a glimpse on the video that is going to be played. In today's webinar, we will be having the case discussion on pediatric hematology. Now, without any further delay, I would like to welcome the moderator for today's webinar, a very renowned personality, Dr. Prashant Karia, sir. Sir, without any further delay, I would like to hand over the webinar to you. You can proceed, sir.
Thank you, Batul. Correction, I'm not the moderator. I'm just the host from the project coordinator. So welcome one and all to today's eGurukul, a PG case presentation. A PG case presentation is a unique way in which the PG students are presenting a case and the two experts are actually asking them the questions like they are asking in an exam. So it's their preparation for the exams, and we are glad to have experts with us. So I request my joint project in charge, Dr. Nehal Patel, to introduce today's case presenter and experts. Thank you.
Hi, good evening all. I'm very much excited for today's case discussion, and we have our both the renowned faculties as a expert. So I introduce first Dr. Neeta Radhakrishnan ma'am. She is associate professor and head at the Department of Pediatric Hemato-Oncology in the Postgraduate Institute of Child Health, Noida. She has done her MD Pediatrics from the University of Kerala and Fellowship DNB in Pediatric Hemato-Onco from Sir Gangaram Hospital, Delhi. She has also done the Fellowship in Hemostasis and Thrombosis from the University of Milan. She had many professional positions in the IIP also. She is the an Honorary Secretary of Pediatric Hemato-Onco Chapter of IIP and co-chair of SIOP Global Health Partnership. She is Vice President, Indian Society of Primary Immune Deficiency. Welcome, ma'am. A very warm welcome to you. And our second expert, Dr. Preetham Singh Roy. Sir has done his MD Pediatrics from PGI Chandigarh, and he is DM Pediatric Hemato-Onco from PGI Chandigarh. Sir is affiliated to, he is an associate consultant in the Pediatric Hemato-Onco Medica Super Speciality Hospital at Kolkata. And he has many publications in the index journals, international as well as national. I welcome, sir, you again also. Thank you, sir, and thank you, ma'am, for accepting our invitation and joining as an expert.
Thank you for the opportunity.
We are having Jaldi. She is the third year resident at AMC Met Medical College, and she will be presenting the case today for hemato-oncology. Her mentor, Dr. Dr. Archana Shah. She is professor at AMC Met Medical College, and we are expecting ma'am to join in a short while. So all the best, Jaldi, for today's case discussion. Our sir, Baldev Prajapati sir is not able to join today. He has some commitment in another conference at Goa. So I request both the experts to take charge of the whole session, and please comment and give your expert opinion wherever it is required. Dr. Yogesh Parikh, who is the convener of this platform, he has also sent his well wishes for the same. Thank you. Jaladi, all the best.
Thank you, Dr.
So you can share your screen.
Good evening, everyone. I am Dr. Jalati Bhatt from AIMSMET Medical College, presenting a case on hematology. My patient being Bhavya Solanki, a 7-year-old male child. By caste, he is Luhana. Informant being mother, who is a reliable source. Bhavya Solanki is born out of non-consanguineous marriage, belonging to lower socioeconomic class, and he came to LGH on 21/7/22. Bhavya is a known case of transfusion-dependent beta thalassemia. Currently, the child has no active complaints, and he has just came for his routine follow-up and for his routine blood investigations. Bhavya's onset, duration, and progression. I would like to start from the antenatal period for this particular patient. Bhavya's mother, she was on regular antenatal checkup. During at that time, she was diagnosed to be moderately anemic. So his mother was advised to go for HPLC report, and she was diagnosed as a thalassemia carrier state. Due to which, after mother being diagnosed as a thalassemia carrier, they were advised for the father also to get screened for the same. And where his father was also diagnosed as a thalassemia carrier, both of these parents, we have the reports with us. Both of these parents are heterozygous for IVS15 GC mutation. After that, the antenatal thalassemia screening for the fetus was advised. An amniotic fluid screening was done at 4 months of amenorrhea, for which fetus was found to be homozygous for thalassemia gene IVS15 GC mutation. After delivery, the patient was lost to follow-up since the patient had no symptoms for almost another 4 years. At 4 years of age, Bhavya came to LGH and he presented with pallor, with complaints of pallor, not eating well and not gaining weight. Since they already had the reports with them, the antenatal HPLC screening of both the parents and also the amniocentesis report of the child, knowing the antenatal history and the thalassemia status of the parents, further investigations were done. At the time of presentation, that is at the 4 years of age of the child, his hemoglobin was 4.6 gram per deciliter. And HPLC report of the patient was also sent at that particular time, which was suggestive of homozygous inheritance of thalassemia. We also have the report of the patient's HPLC available with us. At that time, hematological expert consultation was done of the child, and the first blood transfusion for this patient was done at the age of 4 years. After that, initially for 1.5 to 2 years, the patient's requirement for transfusion was once every 4 to 6 weeks, where his pre-transfusion HB was kept around 10 gram per deciliter. Before 1 to 1.5 years, by expert hematologist, pediatric hematologist, the patient was started on oral medication. Initially, patient was started on tablet hydroxyurea, where he used to take 3 tablets per week. Currently, patient is on hydroxyurea regimen of 5 tablets per week, along with folic acid and calcium supplementations. According to his records, patient was given his 16th blood transfusion in the first before 15 to 17 days, that is in the first week of July. By all of these records from his thalassemia diary and from all his records, number of transfusions, his yearly requirement came out to be 120 ml per kg, and patient is a registered case with Thalassemia Society. Family history. Bhavya is born to a second Dravida mother with one elder brother of 9 years of age.
Sorry, Jaladi, may I interrupt at
Yes.
evening? So may I interrupt at this juncture before we to proceed to the further aspects of history? In the segment of chief complaint, I think you started saying that is a patient with a known diagnosis of transfusion-dependent thalassemia. And then you quite well discussed about the antenatal diagnosis of the beta thalassemia trait status of both the parents, and then how the history evolved of his transfusion requirement. But if I would have been at your position as a trainee and presenting the case, probably I would formulate the chief complaint saying that 7-year-old girl child or 7-year-old boy having transfusion dependent anemia from 4 years of age requiring regular transfusion. I think I will formulate in that way, and I will not break the diagnosis of thalassemia major or transfusion dependent thalassemia at the very first contact when you are projecting your chip complaint to the examiner. I will rather like to keep a bit of suspense by just projecting it as a case of a transfusion dependent thalassemia, which is a transfusion dependent anemia who is having onset of transfusion at 4 years of age. That will be my chief complaint if I present. It will be my personal preference. Nita madam is there, we can always discuss, but I feel probably if I would have been in your position, I would have presented like that. Even we can all discuss. I don't know which one is better. Maybe everyone is correct, but that's how I will project.
See, many examiners would prefer that you don't divulge the term thalassemia, although in your case it's almost all diagnosed and parents are very well aware of the disease. So you can tell them that the parents are aware. So this is a case of thalassemia. But yeah, I would also present like you only did, that this is a child currently admitted for transfusions without any complaints, but then ask for complaints. So because he's been on regular transfusion, you can ask some, as in if he's coming for transfusion, if he has any difficulty, like any difficulty in climbing stairs. So subtle symptoms of pallor also, if you want to ask, you can ask at that time. I think since you are maintaining hemoglobin around 10, he may not be symptomatic at all for that point of time.
Yes.
So let's finish the history, then we'll take up.
I would like to continue with family history. Bhavya is born to a second Dravida mother with one elder brother of 9 years. Both the parents are thalassemia minor, and elder sibling is also thalassemia minor, with no history of any blood transfusions to any of them. Father is a school van driver, mother being a housewife, and the family belonging to a lower socioeconomic class. There is no significant history of any chronic illness, TB, asthma, blood transfusion, or any abdominal surgery in the family. Birth history. Bhavya is a full-term normal vaginal delivered in hospital, birth weight being 2.3 kg with no history of NICU admission. Immunization history. Child is fully vaccinated for age according to NIS. Also, child has taken hepatitis B vaccine according to age, that is 5 years of age, his hepatitis B vaccine has been taken. Diet history. Patient is on full family pot diet and he has been advised tea with his food, which he takes regularly. Developmental history. Child currently goes to school, studies in first standard at present, and he is good in studies. Development in all the 4 aspects is normal for his age.
Can you summarize now?
Yes. We are discussing about a case of a 7-year-old male child here, who is a known case of transfusion-dependent anemia, comes for regular blood transfusions at our hospital with regular follow-up of his blood investigations, along with his HIV, HbSAg status. Currently, the patient is transfused with pre-transfusion hemoglobin of 10 gram per deciliter. Patient was antenatally diagnosed for thalassemia, beta thalassemia, with homozygous state of IVS15 GC mutation, with fully vaccinated for age, and with normal development according to his age.
So when was this antenatal diagnosis done? At what period of gestation?
4 months of amenorrhea, that is around after at 14 to 16 weeks of gestation.
So the parents were aware that the child is going to be thalassemia major.
Yes, they were aware.
And they opted against medical termination of pregnancy, is it?
Yes.
So why was antenatal diagnosis done if they were not willing for an MPP?
Mother used to go for regular antenatal visits where her blood investigations were done, and she was found to be moderately anemic. So according to routine screening,
generally, if a family has any reservations for a medical termination, then they will generally tell you upfront. That's why I'm asking you.
Yes, actually, they were not opting for medical termination. They wanted to continue with the pregnancy because
is it permissible for us to advise, as in we generally, again, we will not give them directed counseling. We'll just tell them that these are the options and the family decides. So like in this case, the family decided not to terminate. Many families may decide. But till what age is it legally permissible to terminate?
Ma'am, till 20 weeks of gestation, 5 months of amenorrhea.
So now recently it has gone up to 24
weeks. Yes.
So now if you have a pregnancy which is beyond that, and in beyond 20 weeks, if there is a medical board that decides that the disease is has significant medical difficulties will be faced by the child, they can terminate after 20 weeks also, provided there is a medical board and it's certified by 2 different doctors, it is in a hospital setting, etc. Okay. I think you mentioned in the beginning that they are a Lohana caste, right? So why did you mention that?
Ma'am, thalassemia is most commonly seen in some particular castes. Lohana, Sindhis, Gujaratis especially, and Punjabis. Thakkars, in case of Gujarati, in the state of Gujarat, these are the most commonest caste in which thalassemia has been seen or has been diagnosed.
So out of 100 normal population in northern part of India, how many do you think are carriers for beta thalassemia?
Ma'am, out of 100, ma'am, it would be around 40 to 45.
40%. Out of 100, 40 people. In which
carrier state is, ma'am, higher.
Where, in which group, which community is it that prevalent?
Ma'am, in Punjabis, it is higher.
What higher means? How much?
Ma'am, I'm not sure.
Around 4%, 3 to 4% is the average carrier frequency. But like you said, in some communities, it may be higher, not as high as 40, but yeah, to the tune of 15 to 20% has been reported in certain communities. And in the eastern part, like HBE, it can be very high. It can be higher than 20% also. Dr. Preeta?
Hi. No, as far as history is concerned, I don't have anything to add, right?
So I wanted to ask her one more thing. Like if you have a family who presents, if you have a child who is presenting to you for the first time at 4 years of age with a transfusion, so what will you call it? Is it major? Is it intermediate? Now you have said it is transfusion dependent. That we understand. But the family would be interested to know, is it thalassemia major or is it thalassemia intermediate? First time transfusion at the age of 4 years.
Ma'am, most probably this is, ma'am, thalassemia intermedia, case of thalassemia intermedia, because if the child would have been a thalassemia major case, then the transfusion requirement would have been as early as 4 to 6 months of age.
So what are the parameters which differentiate between a thalassemia, as in a non-transfusion dependent thalassemia, and a thalassemia major?
Ma'am, any case of thalassemia major, that is transfusion dependent thalassemia, the requirement for blood transfusion would be earlier. Also, on other clinical features, if at all they are not transfused, or if there is inadequate transfusion, history of inadequate transfusions, patient might be having another clinical features such as chipmunk faces or splenomegaly, hepatomegaly, um, uh, all those complications would be present in those cases. If any patient is for non-transfusion dependent thalassemia, uh, patient might not ever be required for any blood transfusion. If at all required, the age of presentation or the age of requirement would be later, as in this case.
Janati, can you give us an unambiguous sort of definition for transfusion-dependent thalassemia? What you tried to say is very correct, actually. But can you objectively give a precise, unambiguous definition of TDT? So for TDT, it's been classically defined as in a child with thalassemia hemoglobinopathy, if you have documented a low HP of less than 7 at an interval of 4 weeks. That is a definition of transfusion-dependent thalassemia. Now, what you told of the different morbidities, which is secondary to this in the form of skeletal deformation, growth failure, etc., can very well be present both in TDT and NTDT. You know, even in TDT, if you are not adequately transfusing them, you will have all the full spectrum of phenotypic abnormalities of thalassemia and the skeletal changes, etc. But that doesn't differentiate between TDT and NTDT. Again, the age at first transfusion, though we typically know that yes, TDT is expected to have at least the first transfusion requirement in the later half of the infancy, like 9 months, 12 months, 1 year kind of. But we do see even TDTs having the first transfusion requirement at a later age because of several genetic modifiers that are also underplay. So, though yes, there is a trend of TDT to have earlier transfusion requirements than NTDT, there is also not a sacrosanct feature that can reliably distinguish between these two entities. The only thing that distinguishes them is having a HB of 7 or less documented at an interval of 4 weeks. And in simple layman's word, TDT is something which will require regular transfusion at intervals to sustain their life. If you don't transfuse them at a regular interval, they would die simply. Vis-a-vis in NTDT, they may or may not require transfusion. If they're not requiring transfusion, they're not dying. They may end up developing multiple chronic morbidities secondary to chronic anemia, but they are not dying because of not getting transfusion. So TDT will die. You cannot continue their life without giving regular transfusion. Whether NTDTs can very well survive without getting regular transfusion, with or without having frank morbidities of chronic anemia. I hope I have been able to dissect it out.
The first time when we transfuse at 4 years of age, when you must have transfused at a hemoglobin of less than 7. So that is the accepted practice, right? But when you transfuse the second time, you have to wait for hemoglobin to drop again to less than 7 to put them on a transfusion regimen. So that is how you differentiate between a thalassemia major, a transfusion dependent thalassemia, from an NTDT. So suppose the second time happens like 6 months later. 6 months later, hemoglobin is dropping to less than 7. This might very well be an NTDT. Whereas if the second drop in hemoglobin is coming very close, it's coming after 3 weeks or 4 weeks, then it is a transfusion dependent and you put them on. No? Then I also noted that this patient is on hydroxyurea. So where do you use hydroxyurea in thalassemia? What is the advantage of using hydroxyurea?
Hydroxyurea is a medication known to increase the level of hemoglobin, fetal hemoglobin, in the circulation. As we know that thalassemia patients have a issue in the beta globin chain. So the normal adult hemoglobin would not be formed in this patient. So for maintaining the HB and also for reducing the requirement for blood transfusion. Hydroxyurea has been a newer regimen to be that has been included.
What are you targeting? Like in your HPLC report, how much was the hemoglobin F? It would be very high, no? So what is the logic of putting hydroxyurea for these children? So in thalassemia major, there is not much of role of hydroxyurea. You can try, if you're trying hydroxyurea, it's basically a trial of hydroxyurea that is tried for non-transfusion dependent thalassemia. And you try to up to a maximum of 3 to 6 months. If you don't see any benefit in that, we generally stop. Even in NTDT, we stop. And TDT, there is no benefit because anyway, you're transfusing them regularly. You're suppressing erythropoiesis anyway. So patient's own erythropoiesis, you are not stimulating it at all in order to reduce the bony changes. So there's no point of adding hydroxyurea in thalassemia to patients who are transfusion dependent. And so when a patient comes to you and you've started the patient on a transfusion regimen. So you mentioned that the child has received 16 transfusions till now, is it?
Yes.
What do you generally, what do you tell them? Like once you start them on transfusion, what all do you tell them? Tell the family?
If once we start the patient on transfusion, we will first of all explain them about the disease, and as we will also tell them about regular screening of HIV, HBsAg. Also, since the patient is transfusion dependent, we will also be screening for serum ferritin for iron overload. We have to explain this to the end, especially we have to explain to the parents about regular follow-up for this patient for fall in hemoglobin levels or any other symptoms that child might develop.
Okay, we'll come back to that question later once you finish your examination.
Should I go ahead with
examination?
Yeah, please. I have examined the patient in proper light and exposure. Patient is was fully conscious, oriented to time, place, and person, fairly built and fairly nourished. Vitals were temperature normal, pulse 88 per minute, good volume, respiratory rate around 20 per minute, regular. Blood pressure was in 50 to 90 centile. Child's anthropometry at current age is height is 112 centimeter, which is 89% of the expected. According to the growth chart, which falls at the 50th centile for his age. Weight 18.6 kg, which is 77.5% of the expected. And body mass index was 14.8 kilogram per meter square, which is between 25th to 50th centile, according to the growth chart.
Jalati, which growth chart do you use for this particular child?
Sir, IAP growth chart of age 5 to 18 years for boys.
Right. What is the other growth chart that can be used for this particular age?
Sir, another could be, sir, 0 to 18 years age, IAP growth chart itself with mid-parental height and...
that is all right. Anything else apart from Indian Academy of Pediatrics chart? Any other growth chart applicable for children beyond 5 years of age?
Sir, WHO anti-growth chart could be used.
So I think WHO is up to 5 years of age, and then you use CDC growth charts?
Yes, sir. We can use them.
Right. So out of like CDC versus IAP, if I want to compare, I mean, if like, let's say I give you option of CDC growth chart as well as IAP growth chart, which one will you prefer and why for your child, for this index child?
Sir, I would still prefer IAP growth chart because in the Indian setup and according to the Indian growth of any children, the IAP growth charts have been formed according to the Indian criteria. I am not as such used to CDC growth chart, so I would surely like to learn I would
Sure.
surely like to learn, but for this particular patient in this Indian setup, I would still go for IAP growth chart.
It's perfectly fine. So can you just name two age-independent anthropometric parameters?
Age dependent.
Independent. Age-independent.
Age independent. So one will be so after 5 years of age, head circumference would be, sir, age independent.
Sort of, yes.
And also, sir, weight would be age independent, sir.
How come weight will be age independent? Weight will be definitely age dependent, no? So it is mean upper circumference up to 5 years of age is an age independent parameter. Another one is one of the ratio of MUSC with head circumference, the so-called Kanavati index, another community level index. Basically, by asking, I just kind of pulled your leg to emphasize the fact that whatever the underlying case may be a pulmonary case or hemato-oncology case, anything, your examiner is very much in a liberty to stop you at any point and start testing your general pediatric pillars like growth, development, immunization, right? So you should be having all these things on your fingertips.
Yes.
Carry on. Thank you.
Thank you. In general examination, there were no hemolytic phases that is particular for the thalassemia major cases were seen. Pallor was seen in conjunctival mucosa, oral mucosa, and nail beds, but there was no jaundice, that is, no signs of icterus were seen. No signs of clubbing or koilonychia seen in this patient. In systemic examination, I would like to concentrate only on the abdominal examination. For abdomen, liver was +1 centimeter below the rib margin in the right midclavicular line, and spleen was also +1 centimeter palpable below the costal margin. Other systems were clinically NAD.
Yeah, please summarize your history and examination altogether now.
A 7-year-old male child presented with complaint of pallor and difficulty in feeding at the age of 4 years of age, who was antenatally diagnosed for homozygous state of thalassemia mutation, and was started on transfusion dependent regime at the age of 4 years with mild undernutrition, fully vaccinated for age, a full term normal vaginal delivered child.
So that's all right. So whenever we present the final database of a child with thalassemia or any other chronically anemic patient requiring regular transfusion, I think two important information that should or must be included in the database is: number one, what do you think the patient is about the adequacy of transfusion? Do you think, based on your history and examination finding, is the patient adequately transfused or inadequately transfused? That's question number one. That information should always be given. And the second is that whether the patient is suffering clinically from any sign of iron overload secondary to chronic transfusion. That may not be applicable for all ages, but always keep in mind, may not be applicable for a child who is as young as 6 or 7 years of old.
Yes.
But these two things should be always mentioned. So my first question, so I will like to ponder on that. What do you think from your history and examination? Now you know the patient fully. Is the patient adequately transfused or inadequate transfused? Tell me if you think adequate, then what are the pointers? If you feel inadequate, then tell me what are the pointers for.
The patient is being adequately transfused. According to this recent reports, so patient was last transfused in the first week of July, and now again after 15 to 20 days, his hemoglobin did not fall below 10 gram per deciliter. Also, the serum ferritin report, which was done in the month of May in this year particular, so it was 635 microgram per liter.
Ferritin
No,
is
does serum ferritin represent adequacy of iron, adequacy of transfusion?
No, sir. It won't be. No, sir. It is
So
not
just
a.
summarize the clinical indicators here. You told it is a patient has been adequately transfused. I do agree with you completely.
Yes.
Tell me from the history and from the examination finding, what are the 1, 2, 3, 4 points that is supporting that the patient has indeed received adequate transfusion?
Yes. Patient has not yet developed any signs of chronic anemia, anemic state. Patient has not been. Patient is not having clinically any signs of intramedullary erythropoiesis at current. Patient has no chipmunk faces or no abnormal enlargement of the head is also not there, which we might be thinking of any extramedullary erythropoiesis. Also, the systemic examination, so liver and spleen both are palpable, but they are just plus 1 centimeter below the costal margin. So organomegaly is not of a higher grade.
Very true. And the growth also have been normal. So if you have to summarize, always the pre-transfusion hemoglobin had been around 10 historically, and as the examination findings are concerned, there had not been any overt skeletal changes indicating medullary expansion. Spleen size is not massive, indicating that significant degree of extramedullary hematopoiesis is not happening in the spleen, and your growth parameters have been pretty well. Then the child is thriving well. All these are the examination finding pointing towards adequate transfusion. And lastly, I would object to your last adjective you have given, mild undernutrition. So these are politically, scientifically, bit unscientific term. Like, can you define what is mild undernutrition? We don't know what is mild undernutrition. We just know, as far as the most of the growth parameter terminologies are concerned, we know what is called moderate wasting, moderate stunting, severe wasting, severe stunting. There is, I don't think any scientific definition exists for mild undernutrition.
Yes, so
So it
there
is
is
not.
no
So
scientific.
try refraining from using terms which are not scientifically well established.
So I'll take up on that same note itself. Like, one is, you mentioned that the child is not chelated at all. So according to you, is that a correct thing to do? When do you advise chelation?
So, ma'am, mostly after 10 to 15 transfusions, we go for screening of the patient for sorry. We go for screening of the patient. Most commonly and most cost effective for government setup is serum ferritin. Also, another organ specific iron deposits could be evaluated, but cost effective is mostly serum ferritin, which in this case came out to be 635 microgram per liter 2 months back. So currently the patient is not on any oral chelators or not on any chelation therapy. Usually we start chelation therapy once the serum ferritin level increase more than 1000 microgram per liters. And after initiating the chelation therapy, we try to maintain the serum ferritin levels at around 1000 to 2000.
So when you start, do you think serum ferritin is a good marker that you can believe? So suppose the next transfusion, after four more transfusions, you repeat a ferritin, that also comes as 600. Are you happy not to start chelation for this child? So do you think, in other words, is what is the fallback, as in what are the fallacies of ferritin as a marker for iron overload?
Ferritin would be calculated, it being an acute phase reactant. It could be higher in any other conditions also. If the patient came to me with the current situation of any stress, like any infection, acute infection, it may be high. If the patient again has a serum ferritin level of 600 after 4 more transfusions, but if I suspect that patient might be getting iron deposits in other organs, I might opt for another test, like for cardiac overload, I would go for MRI screening or other tests.
So usually we do not advise before the age of 10 years, but then if there are cases like this, some children, especially NTDTs, may not have high ferritins, but this is a transfusion, a child who has been transfused as a TDT. So it should be comparable, but in case if that is not, you may have to resort to other ways of doing it. One more question was this regarding this fully immunized. You said the child is fully immunized. So in a child who is a thalassemia patient who is requiring recurrent transfusions, what are the vaccinations that you will say that the child has to get as a must?
Ma'am, as a must, ma'am, hepatitis B vaccine is a must, since hepatitis B is a blood, could be transfused with blood.
What else? The hepatitis B the child has received, right?
Yes.
What else?
Other vaccinations, ma'am, which I would like to, if at all,
so other than the usual vaccines which are given, is there anything else you would advise the family?
ma'am, in this particular child, ma'am, I would not be suggesting any other vaccines in this particular case, because child's overall blood requirement has not been greater than 180 or 200 ml per kg per year.
That got to do with vaccination.
Ma'am, if the requirement is more, then ma'am, we might be planning for splenectomy for this patient.
No, I don't think we've splenectomy. Your patient is very well transfused and hardly any. So don't even go there, and we don't even advise splenectomy for majority of patients.
Yes.
So the other vaccine you would advise is Hep A, hepatitis A. Why would you advise hepatitis A in thalassemics?
I don't have any.
Because they are already prone to liver damage. So you don't want any additional thing which can be preventable. Hep A is so easily preventable by vaccination. So you don't want to add to any other additional insult to the liver. So they always Hep A and Hep B has to be given to all these patients. Okay. Next. So when the child came to you at 4 years of age, we'll start from there again. So once the child came to you at 4 years of age, what was the hemoglobin at that point?
Ma'am, at that point, it was 4.6 gram per deciliter.
So if we do a peripheral smear at that time, what all do you look for in the peripheral smear?
Peripheral smear, ma'am, we will look for microcytic cells, macrocytic, hypochromic, anisopoikilocytosis would be seen, plus target cells would also be seen in such PS picture.
Is there any peripheral smear finding that you can use later to look for adequacy of transfusion? Dr. Preetham just asked you whether the child is adequately transfused. So is there anything I can see in between to say that, okay, my pathologist will tell me, no, this child is very well transfused. Is there anything in the smear? What have you said when you're transfusing very well? There are no bony medullary changes. You just mentioned no? This child does not have any Chickman species. So there is no medullary, intramedullary cell death is reduced. Marrow is suppressed. So when marrow is suppressed, what happens in the peripheral blood? What do you stop seeing? Something which was there initially, it has stopped coming in the peripheral smear. Peripheral blood.
Nucleated RBCs would not be seen.
Very good. What is, how do you recognize a nucleated RBC? How does it look like?
Ma'am, as such for nucleated RBCs, ma'am, we will go for retic count, if I'm not wrong.
Retic count is one step. Reticulocyte is one step.
One step.
Nucleated RBC.
Yes,
nucleated RBC you can see in a normal peripheral smear also. Dr. Preetham?
So in the corollary of NRBC, I just want to share, and I mean, sometimes it happens a very funny experience that, you also might have experienced, Jalati, that sometimes in a child with newly diagnosed thalassemia, when they're coming for the first time as an infant with severe anemia, sometimes Coulter, it just erroneously count nucleated RBC as WBC because it cannot differentiate often. So it can give us spuriously very high TLC. So it has happened sometimes that lab reports came as a TLC of 40,000 or let's say 70,000, 80,000. Peripheral smear has not been examined, and erroneously the patient has been, given a provisional diagnosis of acute leukemia, started on allopurinol, overnight hydration and all. And later on the next day we morning laugh out saying, oh, there was nothing like a blast and it was all in. And this is just a funny thing. Okay, so I wanted to ask you a couple of questions. So let's say for your child that this patient came at 4 years of age, had low HP and subsequently requiring regular transfusion, right, at fixed interval. So let's say if the story was a bit different, that this patient came at 4 years of age, there was low HP, you transfused, and then the patient remained uh, uh, normal, or the HP never dropped for a period of 6 to 8 months, and then again it dropped, right? So in that context, you will label the patient as NTDT because
Yes.
the patient is not requiring monthly transfusion, so-called. Now, in a patient with NTDT, can you think of some situations in which that patient will be requiring regular transfusion? Am I clear in the question? In a patient with a diagnosis of NTDT, can there ever be such situation in which the patient, you being a hematologist or pediatrician, would recommend the patient to go for a regular transfusion? Am I clear in the question?
Yes, sir.
Previously diagnosed NTDT, can the child suddenly start requiring more?
Requiring regular blood transfusions.
Or maybe you yourself decide to put them on a transfusion regimen. So what are the possibilities? What are the scenarios? That's what he's asking. The question is, once if it is NTDT, does the child stay non-transfusion dependent lifelong?
No, the child can be a transfusion dependent later on. So such conditions could be due to any chronic infection in the child.
Usually, when do we transfuse NTDT? 3 scenarios. 1, if there is infection. 2, if there is a surgery or any stressful event. And 3 is technically during pregnancy. We don't see that period, but these are the times when these NTDT patients get transfused. But sometimes we ourselves will say, okay, this child is 10 years NTDT, but he's not doing well. We have to put him on a transfusion regimen. When will you advise that? What is that not well scenario where you will put them back to a transfusion regimen? You must have seen till now NTDT patients, right? Children who have not required, maybe they come once in a year to you. How do they look like? Do they look like thalassemia major children only? This kid is a very well transfused child. So this child does not have any facies, no splenomegaly. Do NTDT children also look like that? Or do they look different?
Ma'am, NTDT, they won't be having any signs of extramedullary erythropoiesis. All we find them to be to have such changes if per abdomen findings have changed, if organomegaly is there, then ma'am, we might plan to shift the patient as a transfusion dependent.
So do you mean that NTDT patient have less frequency of having skeletal changes, organomegaly, etc., as compared to TDT?
Yes.
No, that's not the case. In children with TDT who are regularly well transfused, they will not, just like your index patient, they will not have overt signs of morbidity secondary to chronic anemia. They will not have deep spleen. They will not have facial or other skeletal changes that is seen in hemoglobinopathies. They will not have growth failure, just like your index child. Vis-a-vis in children with NTDT, particularly in the moderate severe forms of NTDT, they will often have the overt signs of that. So my question was also basically around that point only. So in a child with NTDT, if at any point of time, if you see that the patient is frankly suffering the morbidity of chronic anemia. That morbidity can be growth failure. That morbidity can be chipmunk fishes development. That morbidity can be a bulky spleen, which is, a humongous spleen, which is suppressing his appetite, etc. Or you feel the spleen is so humongous that it can rupture any day spontaneously. Or it can be some rare things like development of pulmonary hypertension, venous ulcer. We don't see very commonly, but these things can also happen in children who are chronically anemic. So if you're seeing on your face that one fellow with NTDT is having frank features of morbidity secondary to chronic anemia, you need to start the person on regular transfusion. That regular transfusion may not be a decision for lifetime. It may be just to support their growth, development, and to just overcome the morbidity for a couple of months or couple of years. So what we are trying to emphasize is neither the diagnosis of NTDT is lifelong. It can very well switch to TDT. But even if you are taking a decision to transfuse a patient with NTDT, that decision of transfusion also is not labeled for lifetime. It may be just to just to cover up a few months or few years of life during their active growth, development, just to cope up their morbidities of anemia, and then you can again go back to non-transfusion regimen based on your clinical judgment. So NTDT is more of a dynamic ball game as compared to TDT, which is a kind of 1 or 2 point diagnosis and documented 2 different low hemoglobin less than 7, 4 weeks apart. You label a diagnosis of TDT and lifelong go on having moderate transfusion regimen, regular transfusion. Whereas in NTDT, it is more of a dynamic ball game in which more than the hemoglobin, these are other parameters like the growth, skeletal changes, and other mobility should always be taken into account when you decide for requirement of transfusion. Am I clear on that point?
Yes.
In that scenario that Dr. Preetham mentioned regarding nucleated RBCs, he told you that they are going to come with very high WBC count, right? Why is that? Why are they coming with high WBC count at diagnosis?
Ma'am, ma'am, since the PS picture has not been seen yet, and the machine is counting, ma'am, so mechanism of the machine is
nucleated RBC is getting counted as a
WBC. Yes.
So how can you correct it? Like when you would ask the pathologist, I really want to know the correct WBC of this child. So how do you correct for that?
Ma'am, PS picture would be different for RBC staining, and WBC staining would be, ma'am, stains are different. So ma'am,
it will be stained in your usual hematoxylin staining only. You can see you can differentiate both nucleated RBC and WBC. That is there. But then if the WBC count is say 60,000, you want to know the actual WBC count. So how do you calculate? So this may be asked for you in your in OSCEs as well as in theory as well. So there's a formula for corrected WBC count based on you have the observed WBC count, which is say 60,000, and then you can into 100 divided by NRBC divided by 100. So if there is a formula for that, so if you know the nucleated RBCs, and you can minus the nucleated RBCs from 100 and multiply that thing into the observed WBC count, you can tell the actual corrected WBC count. So many times patients are admitted with sepsis. Many times when you have a high TLC, high spleen, etc., and anemia, patients get wrongly diagnosed as malaria or some infection, and they get admitted in pediatrics because of that. So if you have a very good pathologist, the pathologist can make a difference. So in this patient, after your peripheral smear, so say your peripheral smear is coming as showing these features, which like you mentioned, anisopoikilocytosis, microcytosis, some target cells. What is the next investigation that you would do?
Ma'am, if the peripheral picture is suggestive of such changes, and since in this patient I already knew antenatal
diagnosed patient, I'm not talking about this one. Generally, when you have a patient who is coming at 4 years with the severe anemia and this features and peripheral smear, what is the next advice, that next transfusion, next test that you would do?
Ma'am, I would like to go for HPLC for this patient, since the patient presented with severe anemia.
So suppose the patient has come at night and come with CCF with a hemoglobin of say 2 gram percentage. And the SR who was there at that time has advised emergency transfusion. You are seeing the patient the next day morning. So now what can you do? How will you diagnose? Can you send HPLC now? Should you wait? What will you do?
No, ma'am, HPLC could not be sent now since once transfusion has been done. So I would keep the patient in follow-up. And also, ma'am, we can partly diagnose this child based on the Menser index.
What is Menser index? Where do you use Menser index?
Ma'am, if it is, ma'am, usually, ma'am, in thalassemia patient, ma'am, it is seen that Menser index is less than 13.
Where do you use it? In which scenario do you use Menser index? Is it used for thalassemia major or
No.
is it used for something else?
Ma'am, as such, it is not used, ma'am, but just for.
It's a very good marker. But where do you use it? In Menser index, what are you looking for? What are the parameters in Menser index?
What is the denominator? What's the numerator?
RBCs and mean corpuscular
MCV
and
MCV and
RBC.
RBC count. These are the two parameters, right? So where is it helpful? In which scenario, clinical scenario, is it helpful? You want to differentiate?
Think about the two very common microcytic anemia that you come across in your daily pediatric practice, which needs sometimes to be differentiated. What are the two conditions? Common microcytic.
Most common is iron deficiency anemia.
Another is?
Another megaloblastic anemia.
Microcytic anemia I'm talking about.
Microcytic anemia.
Alterate. Another situation is alterate. The two commonest situations that we come across in microcytic, one is nutritional iron deficiency anemia, other is beta thalassemia trait. Differentiating these two is been very much helped by Menser index. It doesn't help you to differentiate beta thalassemia major from other situations.
So both your IDA as well as your thaltrate will have microcytosis, but denominator is RBC count. RBC count, what happens to it? What happens in IDA? What happens in beta thaltrate?
Beta thaltrate, ma'am, RBC count would be normal, since would be around within the normal range only. In case of iron deficiency anemia, the RBC count would be below the normal range.
In iron deficiency anemia, RBC count will be proportionately low because bone marrow is not able to produce RBC.
Not able to produce RBC.
There is no iron, correct? So, so when your hemoglobin is low, RBC also comes down. So, correct. Whereas your beta thalassemia trait, what happens? Bone marrow is starting to, little bit of anemia will be there in the periphery. Hemoglobin will be around 9 to 11. And then when your bone marrow tries to produce more RBCs, so your RBC count is actually higher for the degree of anemia, correct? So that is okay, that apart. So my question, I come back to my question. My question was, child is transfused over, has been transfused overnight. You are coming in the next day morning. Now you need a diagnosis. What will you do? Or what could you have done?
Ma'am, we could have taken a sample for HPLC before transfusion also, if we are suspecting the child.
True. That would have been the easiest way to. So even if it's a child in CCF, if you're starting transfusion, just prior to that, you can take EDT and store it. The next day morning, you can send it. So that's not at all difficult. That is one thing. So now suppose a child has been transfused. Now what will you advise? Will you send HPLC the next day?
No, after transfusion, ma'am, we won't be sending HPLC the next day. Ma'am, we can keep the patient on follow-up. Mostly, ma'am, if after transfusion, ma'am, they usually HPLC is to be done after 3 months post-transfusion, 2 to 3 months post-transfusion.
So if it's a
But the-
thalassemia, yes, Dr. Preetham.
But the patient may not give you that much time. No, most of the TDTs will become anemic again within 3 to 4 weeks. So think about how the disease is inherited. How is thalassemia inherited? Where from the disease has come into the baby? From the parents, no?
From the parents.
So what you can do the next day when the patient has already received transfusion, don't do HPLC of the baby, but you have parents available. So you can do HPLC of the parents. Yes. So if you are getting a diagnosis of thalassemia trait in both the parents, that is an indirect evidence that yes, we are indeed dealing with a child with homozygous beta. So I had another question. So homozygous. So do you think there is any difference in the genotype of thalassemia major versus intermedia? I mean, is one homozygous and the other is heterozygous? It's like that, or both are homozygous condition?
No, thalassemia intermedia could be homozygous as well as heterozygous. Thalassemia major is homozygous for the mutation.
Okay, so there is a wrong conception. I asked because frequently I have seen junior residents, I mean, having this misconception. Heterozygous situation is always thalassemia trait. They don't, and you know what thalassemia trait means. Mild anemia to no anemia, microcytosis, and no other abnormality. Thalassemia intermedia and thalassemia major both are homozygous beta thalassemia. Both the beta genes are indeed carrying mutation. Both are mutated. Now, when you say heterozygous, it means one beta globin is normal, other beta globin is defective. That situation is trait. Both major and intermedia are situation when both the beta globin genes are mutated. None of them are normal. Then what makes them express differently? Despite being homozygous, some patient will have phenotypic expression like severe thalassemia major, and some patient will present like relatively less severity, like thalassemia intermediate. So who decides their fate? Both are having defects in both the beta globin gene, and why is the difference in expression of the severity? You got the question?
Yes.
Hmm.
So it depends on the type of mutation that is there. Ma'am, some of the mutation would be in the enhancer region, some would be in the promoter region. So depending on those mutations, the child may present differently. Even if a thal intermediate patient is there, he might be requiring more number of transfusions as compared to a thalassemia major child.
Very true. So it depends upon the type of mutation that decides whether you are dealing with, there's severity like beta 0, beta plus. In beta plus, you have at least some amount of synthesis preserved. In beta 0, you have lost. So there can be different types of mutation that can differ, and also you may not know to get it in MD level. There are sometimes secondary modifiers. Like these are the genetic level issues you were saying. That sometimes mutation can be based on the site of mutation. Sometimes it can be severe, sometimes moderate. But even there can be secondary modifiers in which beta globin, irrespective of the type of beta globin gene, some other modifier, like some modification of alpha, like I'll give some example. Sometimes it can happen, let's say, beta thalassemia trait, and only one beta gene is mutated, another one is normal, but there is concurrent alpha gene triplication. So when there is a lot of alpha beta quantitative discrepancy, so a lot of alpha gene getting precipitated, and they can present with transfusion dependent thalassemia. Sometimes let's say thalassemia co-inheriting with HPFH, some persistence of fetal hemoglobin, that can modify the clinical picture. So you need not know up to that great extent of detail, but you should know that it is not only the mutation, but also several other secondary and even tertiary genetic modifier that can alter, the phenotypic expression of the disease, that how severe the anemia will be, what are the morbidities they will develop. There are other modifiers as well. So that one point I wanted to make. Apart from homozygous beta thalassemia, can you tell us some other hemoglobinopathies that present like thalassemia intermedia? Like your patient was major anyway. But in patients with NTDT, apart from homozygous beta thalassemia, can there be other hemoglobinopathies that present like thalassemia intermedia?
Present as NTDT.
Yeah.
That's what you asked.
Yes.
Certain membranopathies such as
No, I'm talking about hemoglobinopathies.
hemoglobin. Okay, sorry.
These are all quiz questions. So once examiner has reached this level, you should be happy that you have crossed all the 60 to 70% score you have already made. And you have performed so well that all these difficult questions have been asked.
Another thalassemia
Ma'am
intermedia.
mentioned one hemoglobinopathy common in eastern part of the country. So there is a clue for that.
HBE.
HBE beta. HBE homozygous disease is asymptomatic. Yeah. So when HBE is having compound heterozygosity with beta thalassemia, it is quite common in eastern part of the country like West Bengal and northeast like Assam, Tripura, etc. HB beta is something which is very heterogeneous. They can have mild anemia, they can present with NTDT, sometimes occasionally even like a thalassemia major they can present. But by and large, HBE beta present like NTDT. And another hemoglobinopathy that also comes with NTDT are the alpha thalassemias. HBH disease. HBH disease being the prototype of that presents with that. So there are probably two other common other hemoglobinopathies apart from homozygous beta thal that can present with NTDT like picture, right?
So if you find alpha thal, what would you find in the peripheral smear? In addition to whatever you told us till now, is there anything else in the smear that can help you suspect alpha thal? Or in other words, if you suspect alpha thal you generally suspect when you are thinking of thalassemia major, but your HPLC does not show hemoglobin F peak, or scenarios like that. So when you suspect alpha thal, especially HBH, what else do you look for in the smear? Because final diagnosis means genetic workup, right? So before that, is there anything in the smear that can help us say, okay, yeah, this could be alpha thal? What happens in alpha thal?
Alpha thal, ma'am, there are 4 chains. So if any of the gene is absent, so that particular gene would not be.
So one gene absent, is there any problem?
No, it too won't be such a major problem, but.
What will it present as? 1 gene or 2 gene? How do they present?
Ma'am, 1 gene deletion or 2 gene deletion, ma'am, they will be presenting as a moderate anemic picture, ma'am. The
mild anemia, this is usually what they present as. So 3 gene is what is HBH.
HBH.
So how do they present? So we don't see HBH that common because it's not very common in northern part of India. It's mostly in the east and in East Asian countries. So if HBH is suspected, is there anything in the smear? You find what is called Heinz bodies. And then there's something also, again, quiz question, golf ball inclusion bodies. Okay, so these are all because of precipitates of beta globin. And when you're, so that you can look for. You can look for with a special stain. You can ask for both Heinz body as well as golf ball inclusion. This thing. Okay. Now coming back to our possibility of this patient. So if this child is, if I think this child was put on a transfusion regimen after 1 hemoglobin record, right? So do you think, you know the genetic mutation of this child? So do you think this child could be major or this child could be intermedia as well, intermedia or non-transfusion as well, based on the genetic mutation?
Ma'am, this particular mutation, ma'am, most of the patients, ma'am, they fall under thalassemia intermedia category. For this particular mutation, since we know. So
beta plus mutation. What are the other common mutations in India?
619 gene deletion. Then another
this is IVS 15, right? Is there something similar to that? One more very easy thing to remember. One more IVS. Okay, you can read up that, okay? So these are
Yes.
common. There are 5-6 mutations which are seen in our country. That is why if you order a genetic testing, usually, unlike in other genetic disorders, we just ask for the common mutations first. Around 90% patients will come in that only. So you can save money. Even with 1,000 rupees, 1,200, 1,500 rupees, you can get that test done. And if they don't come in that one only, then you need beta globin gene sequencing.
Development
You can
analysis.
save money by getting that panel for common mutations in beta thalassemia. Okay. Now, what else? We'll come back to ferritin. Okay, so what are the conditions where you think ferritin can be falsely high? You mentioned acute phase reactant, it's fever I mentioned. So whenever you will do, you will ask that the patient should not be tested when the child is running fever or any respiratory infection for that matter. What else? What is the other condition where your ferritin suddenly becomes high and you are wondering what went wrong? Like last time, 3 months back, it was 1,500. This time it has come as 4,000. Child did not have any fever at that time of testing. Then what will you suspect?
If there is no history of fever, then ma'am, we might suspect that the patient is having higher free iron in the circulation.
Free iron is a dangerous area to venture into because then you will invite a lot more questions in that. You are suspecting increased iron overload. That's what you're trying to say, right? But why would a child who is being chelated properly suddenly increase? Suddenly, why should ferritin drop have increased from 1,500 to 4,000? Unusual. No? Usually, it goes up step by step. If your chelation is inadequate, then it will go from 1,500 to 2,000, 2,500, that range. And then you have time to intervene also. But if suddenly, if it is shooting up, then what all do you ask for? Two things you will look for. One is compliance. You'll ask the family whether they have stopped anything. Suppose their pump is not working. If they're on desferrioxamine, maybe they've stopped it. Or suppose the child is not taking Kelfer for that matter. So that you will ask. Other than that, what will you ask for? Is there any other infection which can present with just increased ferritin and no fever or anything? Hepatitis C. So if you have sudden increase in ferritin, always rule out Hep C because liver inflammation might be there. It may not present with fever. Sometimes even if you don't even get jaundice also in Hep C positive patients. So if you are getting some sudden increase, the third possibility is that the lab has changed because ferritin is again a test which is highly dependent on the kit that you're using for testing. So suppose you are following up in your own hospital lab, they've got from an outside lab, then that also is a possibility. You should always just hold on that test. You don't increase chelation based on one report. As in one increase of sudden increase, you won't increase. You will wait, repeat after 2 weeks, do a Hep C screening also along with it. And then if it is still going up, then you will increase. Okay. So in this child, for example, after 3 months, you are repeating a ferritin. Now for this time, your ferritin report has come as 1,000. So what is the chelation that you will advise?
Ma'am, since the child is currently 7 years of age, ma'am, I would go for oral iron chelators.
Does age matter? If it is like if the child is say 1 year, what will you opt for? We will anyway opt for oral chelators because they are so good, so easy to use nowadays. No? So which oral chelator would you prefer?
Ma'am, currently Deferrazerox, ma'am, which is the newer, not newer, but oral and most safest, and it is the safest drug available with minimal side effects.
Okay. So you must have prescribed, right, for some patients. So what dose do you advise?
Ma'am, 20 to 40 milligram per day, ma'am. That is the dose.
So when you start on the 7-year-old boy, what was his weight?
Ma'am, 18.6.
18. So what for this 18-year-old kid? How will 18 kilo kid? What will you advise? What is the dose that you will start?
Ma'am, initially I would like to start with the minimal dose itself, that is 20 milligram per kg
So that
per day.
360 milligrams. So what is the tablet strength of the drug?
Ma'am, 100 milligram available in 400 milligram also, 100 or 400 milligrams.
Okay. So you will advise 400 milligrams, is it?
Yes.
So how do you give it? How will you tell the parent to give this drug?
Ma'am, it could be, it should be given in a non-metallic container with a non-metallic stirrer, and it should be given with it should be given with vitamin C.
Vitamin C for what reason?
Ma'am, vitamin C, ma'am, it increases the peripheral availability of peripheral iron would be more, so that more iron would be available for chelation.
Is that true for all chelators or it's true for one chelator?
No, ma'am, it is true for desferrioxamine also.
This is true for desferrioxamine. When you're giving it as an infusion, you are giving calcium vitamin C so that it increases the chelatable iron for desferrioxamine. We generally do not advise vitamin C for the other chelators. Okay, so when do you give it, in the morning, evening, afternoon?
Morning, before meals.
So suppose you've started the drug and next week the parent comes back and saying he has a lot of pain abdomen. What will you advise?
Ma'am, I would like to hold the iron chelators for some time. I might run a panel for RFTs and LFTs, and I will hold the drug for a while.
While means?
Till, if at all the blood investigations are abnormal, if creatinine is high or anything, if up to the time till the blood investigations come back to normal.
The report will come in like an hour or so. What will you look for in the RFT and LFT for a child who's on this drug?
Ma'am, serum creatinine most commonly is seen to be high in cases of this, ma'am, oral desferrioxamine.
Desferrioxamine can cause slight increase, but it's not a very common side effect. And not after 1 week also. Progressively, there can be some increase in creatinine, but never goes into that AKI thing at all. Okay, it's a steady, slight increase in creatinine may be seen while on follow-up. So usually that should not cause pain abdomen also. So gastric irritation can be seen, but generally it subsides also. And you can even, although we advise it on empty stomach, you can give it after meals also. It's not like a big restriction that you cannot give it after meals. So usually it settles down. What are the other side effects you will look for when the child comes to you in the OPD for follow-up? What else will you look for?
In any skin allergic reaction or any dermatitis, if the patient is complaining, I would surely like to check for compliance of the patient on follow-up.
So next week, so the child is on follow-up, tolerating the drug well. 3 months again go by, you are repeating the ferritin, and this time the ferritin is 2000. So now what will you do?
Ma'am, we can increase the dose
Up to? I didn't hear you in between. You'll increase up to?
Your internet connection is losing stability.
Yeah. Now we can hear you clearly. Hello, Jalati, are you there? Hello.
Yeah.
Yeah.
Can
You're
you?
answering very well, Jalti. We're just having, we're just asking you just because you're answering well, right? So what will you do now? How much can you increase Deferoxam?
My maximum up to 40 milligram per kg could be given in 24 hours. Ma'am, not more than that.
Yes. So what happens after that? What will you do? If the child is still having a high ferritin, you're already on 40 mg per kilo, then what will you do?
Ma'am, I would like to shift the patient on 2 drugs, ma'am. Newer regimen, ma'am, shuttle.
Yeah, please carry on.
The second that you will add.
Sorry, ma'am.
What is the next agent that you will add?
Ma'am, desferrioxamine and deferiprone. Ma'am, 2 drugs. Ma'am, one is oral iron chelator. Another, ma'am, it would be given as intravenously or subcutaneously.
You'd ask the parent to choose, as in what will you do? You give them the option, or will you only advise the medicine?
No, ma'am. I would like to give the option to the parents, since regular intravenous or subcutaneous injection would be tedious for the child himself.
So we generally don't give them, as in we don't give them an option to choose, because it's so much easier to give an oral agent. No? So you generally go to the second agent, which is deferiprone. So, and then if it is not working, or if you have some features which either not tolerating deferiprone, only then you go to the parenteral preparation. And parenteral preparation, like you mentioned, is subcutaneous. How do you give? Have you tried desferrioxamine in any patient?
No, ma'am. In my setup, I have never seen any patient on desferrioxamine.
It is given as a subcutaneous infusion over 8 to 12 hours. So it's a pump. You will have to, as in, if you don't have a patient in your center, you should probably read up about it, because that pump as well as all these can be asked in the. So it's a subcutaneous pump. How to dilute the drug and how to give it as a subcutaneous. There is a particular needle which comes for it. All that you have to read up from. There are Thalassemia International Federation guidelines are there. So you have to read up. And it is not given as an IV in usual cases. Okay. Yeah. Then something called emergency chelation. Have you heard about that?
Yes.
What is it?
Ma'am, emergency chelation is, ma'am, if the patient is lost to follow-up or is inadequately transfused, and if the patient comes with iron overload, his heart is compromised or liver is compromised. Ma'am, at that time, ma'am, we will start on the patient on emergency chelation.
What is the difference from what you're giving for this child? How is that different? If a child has impending cardiac failure, what is the difference in treatment that you will offer?
Ma'am, we need faster response.
Yes.
So, ma'am, I would go for the subcutaneous route.
You will opt for
desferrioxamine, or I would go for a higher dose on oral chelators.
Which is the chelator that's been proven to have a good benefit in cardiac failure patients, or it prevents cardiac iron overload?
No, I'm not sure.
Deferiprone has good effect in cardiac iron overload. And when you give emergent, it is usually injectable, parenteral preparation, but it's not subcutaneous, then it is given IV. And how do you give it? As a 24-hour infusion. So you have to put in a large bore needle or a central line and then give as an IV continuous infusion. Only then it will slowly come down if your child is coming with the cardiac failure. What are the other scenarios where you want to rapidly reduce the ferritin? Other than impending cardiac failure, there are 2 more scenarios where you want the ferritin to come down quickly.
Ma'am, any stress, such as, ma'am, if the patient is going for any surgery, or a patient is a candidate for stem cell transplantation? Then, ma'am, we might go for
Transplant is correct. You want to reduce the ferritin as much as possible before transplant. And the other this thing is pregnancy. In pregnancy also, you don't want the ferritin to be very high. So why do you want the ferritin to come down before transplant? What is the harm of going in for transplant with a high ferritin level?
ma'am, one is ma'am, the graft that we would be giving to the patient, ma'am, that higher chances of rejection of the graft if ferritin levels are high.
Not exactly. Basically, liver fibrosis. Liver fibrosis as well as hepatomegaly, these are very, very strong prognostic factors for transplant. So if your child has an hepatomegaly or has a poorly chelated patient, the survival post-transplant will come down significantly because of liver damage. Because during transplant also, you're giving conditioning drugs which can have liver damage. So put together, they can have an adverse outcome for the patient. Okay, so these are 2-3 scenarios where you want to bring down the ferritin. So suppose a family tells you that we are going to get transplant later, then you have to tell them that all the more reason that you should be very well transfused and very well chelated. Very well chelated so that your liver is in pristine condition before you go for transplant. Okay. Preetham?
Yeah. So so as we are discussing chelation, can you tell us what is the most common side effect of Oxamine? It is truly not a side effect, but really bothers patients sometimes. It's not it doesn't harm the patient, but it causes something which really bothers the patient and the parents after you start Oxamine. After a couple of hours after you start Oxamine.
Local irritation.
No, so what I try to mean is promaturia. After you start Oxamine, patients start, because it is a water-soluble iron chelator, so it gets extruded to urine. So urine color gets red. Yeah, so patient assumes it to be hematuria, and they get quite frightened sometimes. So can you tell? So one is a local local reaction, infusion-associated reaction is one. Any other systemic toxicity that long-term Oxamine can lead to? So if you're just using acutely, it's a LVF for a period of maybe 5 to 7 days or 2 weeks, those will not come. But if you're using it on a long-term basis, which is anyway not so common nowadays, what are the potential adverse effects are you looking at?
It has ear toxicity and visual.
What form of ear toxicity? Which structure in the ear get involved? It causes high frequency sensory neural hearing loss. Yeah. What else?
Visual acuity would be affected.
Anything else? Correct.
And what?
Cataracts are also seen. Cataracts.
Yes, cataract also indeed happens. Anything else?
Can be seen. Yes. What do you check in your anthropometry?
Yes.
Yes. There is a one side effect of reduced bone growth also. So
which bone growth? Appendicular skeleton or axial skeleton?
In
axial. Axial. Spine. Yeah. Spinal column is mostly affected.
So you get short stature basically, and your upper segment, lower segment ratio will become shorter because your upper segment is made up of the vertebra, so that will get shorter. So you get a low US-LS ratio, short stature, right? And another thing that is fancy and often books write is development of some of the infection, like serratia, etc. Infection can also happen when you start on DFO injection. Okay.
For that vertebral defect also. What happens to, he said, no, upper segment will become shorter because your spine is becoming shorter. So when your spine is shorter, when you take an X-ray, there's a finding in the spine. What will you find? So earlier, when we used to be students and we had patients, multiply transfused patients were kept for exams. Many of them were on Oxamine. So you have to take sitting height or upper segment, lower segment. Otherwise, that's considered a crime if you're presenting a thalassemia patient. So the finding is platybasia. Platybasia is that vertebral flattening that you see in patients who are receiving desferrioxamine. And what else? Is there, does it chelate only iron or does it chelate something else also? This desferrioxamine. And it chelates something else because of which you can have some more problems. What? So that's again a clue.
Ma'am,
We'll discuss it the other way around. If a child has come with short stature and thalassemia, tell me all the reasons why you can get short stature in thalassemia. One is chronic anemia. Okay, you already said
chronic anemia.
Chronic anemia if the child, your patient is very well transfused, so should not get a short stature because of that. Second is, we already discussed desferrioxamine. Child is getting that, so there may, if the child is on desferrioxamine, you can have short stature. What else? What else causes short stature in thalassemia?
Os
Yeah, you're getting there only. Tell. Osteo what?
Osteoporosis is seen in such patients.
There are a lot of bony morbidities that are seen. It could be osteopenia, it could be osteoporosis that can be seen. Okay. But then that the bony growth that presents mainly with bone pain and things like that, short stature will be later. Well, short stature per se will not be a finding of, not because of osteoporosis. There are a lot of symptoms related to osteoporosis or osteopenia. What else? What else causes, what happens when you keep treating these patients with transfusions? What happens on the bone? What endocrine problems happen because of which you can have short stature?
Endocrinal.
Which endocrinological problem usually causes short stature in children, normal, other children?
Growth hormone deficiency or
more common than growth hormone deficiency?
cortisol related to.
More common than that. One of the commonest endocrinological problems in children.
Hypoparathyroid.
Before parathyroid?
Hypothyroidism.
So hypothyroidism can happen in thal also, right? So hypothyroidism, hypoparathyroidism, then later growth hormone. So if that is not correct, as in the order of appearance, it will be thyroid, parathyroid will may be affected earlier. Then growth hormone deficiency can happen. Zinc can be then. So that is what my question was to that zinc chelation. If children are on desferrioxamine, you can have chelation. And the zinc can also be chelated and zinc deficiency can be there. So zinc deficiency, how does it present usually in children? Symptom wise, what do you see? Other than short stature.
Ma'am, skin erosions, acrodermatitis.
That's like very severe. Other than that? Taste, you lose your taste, right? You lose your taste, you lose your, there can be secondary sexual characteristics can also be delayed. That can also come as a reason, this thing of zinc deficiency. Okay. Somewhere you mentioned splenectomy. So can you tell me where will you advise splenectomy or will you advise splenectomy in patients with thalassemia?
Ma'am, if the annual blood requirement is greater than 200, if recent increase in frequency of blood transfusion is there.
So what are the conditions where you have recent increase in transfusion?
Any acute conditions such as infection is there, hypersplenism.
So this,
Then,
for example, is being transfused once in 3 weeks, is it? Yes. So maybe 1 month later, suddenly hemoglobin for your 3 gram, by the time you're coming in for your next transfusion, suddenly hemoglobin is 7. So you transfuse and send them. Again, 1 week later, hemoglobin is coming down to again 7. So there is a sudden increase in transfusion frequency. So what are the possibilities that you will consider? You said infection. Which infection can come like this?
Parvo virus.
Any
Because of
can come, but
any virus.
infection, if a child has says typhoid along with this, then also for 2-3 months, you may have an increase in transfusion frequency that may be seen. Malaria also, you can see that. Other than that, Parvo virus is very, very important. So how do you look for Parvo virus? How do you test for Parvo virus? Okay, how do you treat parvovirus? So if you suppose you diagnose parvovirus, we generally send a PCR, or you can do a bone marrow also if you want, and you look for a red cell arrest that you can see. And pro-normoblast will be very, very large. So that is a typical finding in parvovirus. How do you treat parvovirus? You'll have to do something, no? Otherwise the child will keep on getting transfused like this. So how do you treat parvovirus?
Some specific antiviral regime, I'm not much.
But then you can give supportive treatment with IVIG. So that may help in few patients. Okay. So the first was infection. What else will you look for if you have sudden increase in transfusion frequency? Clinically, what do you look for in the child? 2 things you have to look for.
Spleen size.
Yeah, very good. Spleen size, if it has gone up or not, you will see. So if the spleen size has increased suddenly, and then probably it's because of the spleen only that there is increased frequency. That is again possibility. Third possibility, infection, hypersplenism. Third possibility. The father tells you, I went home 2 days later, he had high colored urine. See, already Dr. Preetham told you he is on chelating agents. Urine might be slightly red in color. That is normal. You have to tell them and send home. But then suddenly they tell that we went home. After we reached home, the urine was high colored for 2-3 days. Then what do you suspect?
Alloimmunization in this patient.
Very good. So what is it causing? It's causing delayed hemolysis.
Delayed, yes.
So how do you diagnose that? So next time the child has come to you, this time also hemoglobin is say 6 grams. So what test do you advise to diagnose? You're suspecting alloimmunization, right? So what do you do? How do you test for it?
Coombs test.
You can do Coombs test. And then what else will you look for specifically? So Coombs is positive, or whether Coombs is positive or negative, what do you look for? Next, what do you want to see? It is getting alloimmunized against what? Your whatever blood you are giving, transfusing from outside is getting destroyed. Why? Because the child has developed some antibodies. Antibodies to some of the other red cell antigens, right? Yes. So usually you are checking only for ABO and RH typing. So this is
should be checked also, like small c and K DUF antigen. They should also be checked. Means they should also be screened.
Yeah, ideally you should check in the beginning only, but it's not possible in most children. So at least when you have a suspicion, you can do what is called antibody screening. So that will tell you which antibody, the antibody is developed against which antigen. So now say you have anti-KEL antibodies. Now what will you do? How will you prevent alloimmunization next time?
Ma'am, if I know that against which the antibodies have been found, I will transfuse blood other than I will transfuse blood that does not have these antigens.
So you can match it. You can specifically match it to the extended phenotype and give so that you can avoid it. But many a times it is very difficult. So we end up treating these patients for the antibody. We treat them with steroids. We treat them with rituximab, IVIG, etc. to reduce the antibody titer. So that's a very bad complication that you can get because all treatment becomes very intensive for a while. But usually they come out of it and after a while they stabilize once the antibody titers come down. So that was the third reason. Any other reason why your transfusion frequency can increase suddenly? We mentioned infections, spleen increase, and alloimmunization. Anything else? Very common thing and something which is very, very preventable. What are the drugs that you tell them at every discharge? When the child is going home. So now this diagnosis, the child is being discharged. What are the drugs the child is going to be on?
Ma'am, this child will be on oral hydroxyurea and some supplements such as folic acid and calcium.
Why are you giving folic acid? In any hemolytic anemia, why do we give folic acid? We give in any hemolytic anemia, right? Even if it's spherocytosis also we'll give. So why do we give folic acid to these children? In hemolytic anemias, there is a lot of red cell turnover. So when you have a lot of red cell turnover that's happening, you don't want them to become folate deficient. Folate is something which is a water soluble B complex, right? So that is why you supplement folic acid. Suppose the family is not giving the child folic acid, then also you can have increase in transfusion frequency. Then you have to ask them if you have been on folic acid. Otherwise, you just start them on folic acid. Usually, it will the transfusion frequency will increase. But the most common reason is what you mentioned, that is allosensitization. Okay. Dr. Preetham?
Yeah, so just a couple of practical questions I will ask regarding transfusion. These are very practical questions. Number one, you can note the questions. Number one, how much volume do you transfuse? That's question number one. Second thing, how much up to what extent red cell immunophenotyping is recommended by the international guidelines? That's question number two. Question number three, what should be the ideal or maximum rate of transfusion? Often, particularly for the older children, we come this doubt whether we can give 300 ml in a day, 400 ml in a day. So how much transfusion to give in a day, and what should be the rate of transfusion over 4 hours, 5 hours, 6 hours? Should you rewarm the blood? Blood comes at, it has been typically kept in blood bank between 2 to 6 degrees Celsius. So it comes cold. So do you need to bring it to room temperature before starting transfusion, or you start just like that? So question number one, how much do you transfuse at each visit?
So at each transfusion, we usually transfuse at, or it should be transfused at around 15 ml per kg volume. So
second question is, up to what extent you do red cell phenotyping? Routinely, what we just do is ABO and RHD, right? But as ma'am was mentioning just now, that to prevent development of alloimmunization, yes. So up to what extent? Yeah, up to what extent is internationally recommended? There are so many minor blood groups, as you said, M, N, S, F, L, T, that is that. So up to what extent is been recommended by the international guidelines? Bare minimum standard of.
Sir, I'm not. I don't know the answer to this.
Okay, so what is recommended is APO, you are anyway doing. You should do a complete RH typing. Typically, we do only capital T, but small c, small e should also be included in the panel. And also KEL. This up to this much extent of immunophenotyping or red cell typing, you should at least do. There is a bare minimum requirement as a standard of care that is being recommended internationally. My third question was, at what rate?
Rate of
Do
transfusion.
you give over 2 hours, 4 hours, 6 hours, 8 hours? 1 unit of blood.
1 unit of blood over 4 hours.
Can we give faster? And what is the then safe? What is the maximum rate in which you can transfuse blood?
Rate is I'm not able to recall the answer.
Usually when
So
child comes to you, how many hours do you give the transfusion?
Usually 2 hours to 4 hours, not lesser than that.
that's correct. So so usually what has been told, the until and unless there is any associated comorbidity, like let's say impending cardiac failure or any other cardiac morbidity, etc., a rate of up to 5 ml per kg per hour can be safe. So we typically give 15 to 20 ml per kg at a single visit. So you can very well complete the transfusion over 3 to 4 hours. So I think after the blood unit has been dispensed from the blood bank, utmost effort should be made to get it transfused completely over a period of not more than 4 hours, right? And my fourth question was, do you rewarm to a normal temperature before transfusing, or do you just start the transfusion?
So we will just.
The sister will tell you, let us keep it on under the pillow for some time and then let it warm and then we'll start the transfusion. Do you agree? Do you not agree?
I will warm the blood before transfusion.
Right?
You really need not, you really need not do rewarming, and it can actually be transfused from the point, the temperature in which it reaches doesn't really make any difference. You should not rewarm, and you should start transfusion at the temperature in which it's been distanced from the blood. So these are some very common things, no rocket science, but the common mistakes sometimes we end up doing in our practical. Okay, so one googly question I was thinking for last couple of minutes. So let's say a child with confirmed diagnosis of beta thalassemia major, right? HPLC is very much confirmative of a diagnosis of beta thalassemia, and you did parental HPLC. You found the father to be beta thal trait, but mother's HPLC is normal. This is a mystery, no? You expected both of them to be beta thal trait. You found father to be beta thal trait, but mother is having normal HPLC. So what do you think? What could be the reason? What are the possible reasons do you think of this? You got the question?
Yes, sir. Mother might not be screened for all the mutations.
Sorry, I couldn't get you.
If we are screening the mother and if we are getting the HPLC report, then mother might not be screened for all the mutations, as well as
No, even if the mother's HPLC is normal, mother is not beta thal trait as per the HPLC reported. So my question is, then why from the baby? So baby is homozygous, means baby has acquired 2 mutations. One from father, because father's HPLC is suggestive of beta thal trait.
Right.
But where from the other mutation came? Mother is normal. You got the googly. Okay. So think of like how do you diagnose thalassemia trait based on HPLC? What is the indicator of thalassemia trait in HPLC? Which particular parameter do you look at?
HbF and HbA.
HbA2. It is HbA2.
HbA2.
So high HbA2 beyond 3.4% is considered. So can you think of the situation in which erroneously HbA2 can be low?
What is the cutoff above which you will say HbA2 is elevated or suggestive of beta thalassemia trait? So in this child also, the parents were tested as straight, right? So what would have been the HbA2 level?
It should be value for trait is 4 to 6%. HbA2 level 4 to 6%.
3.4. Above 3.4 is what you are calling as abnormal. So Dr. Preetham's question is, can be falsely low due to any condition? So in more than 3.4, the lab will tell you that it's elevated. And they are not coming to us. They're actually going to gynecologists. So 3.5 or 3.7, the gynecologist has picked up and got the father tested, right? Very well tested also. Timely testing. But suppose it is coming as 3.1. Can it still be thalassemia trait? The question itself, the answer is yes. But you have to tell us the reasons why it can still be thalassemia trait.
It's iron deficiency. Concurrent presence of iron deficiency can, lead to a falsely or erroneously slightly low HbA2, even if a patient is beta thalassemia trait. So it can basically mask your diagnosis of beta thalassemia trait on HbA2. It is not an uncommon condition that you come across. So our I distinctly remember our hematologist, Professor Rina Das, saying that whenever they get HbA2 level somewhere between 3 to 3.4, they always give an empirical course of iron and then repeat after a period of 3 to 4 weeks, just to be in the safer side to not miss any such masking. That is one of the major reasons sometimes your HPLC get masked and you can miss a diagnosis of beta thalassemia trait. There are other couple of rare situations, like some of the particular mutations of beta globin gene, like a CAPTAS1 mutation, etc. There are a couple of mutations, some 0.101C2T mutation. There are a couple of mutations in which, despite the mutation being present, you can have normal HbA2. So you can have a silent mutation in that state. So you are genetically mutated, but it is not been expressed on HbA2. That is another situation in which your thalassemia trait diagnosis can get masked. Another situation. So these are the situations in which you can have a child with thalassemia with one of the parent not having trait identified on HbA2.
I have two last questions for you. One, quickly, diet. What will you add? You said that this child is taking tea with meals. What is the logic of tea with meals?
So tea is known to contain tannins, which will decrease iron absorption overall. So since patient is on transfusion, already iron would be more. So this will decrease the iron absorption through foods.
Okay. What are the dietary restrictions that you will advise for a patient with thalassemia?
Restrictions, ma'am, I would advise patient to not consume citrus fruits. I would advise the patient to not take any iron supplementations. Or any iron-rich foods.
We will not advise any restrictions. Okay. Child can have anything what the child wishes to or what the family prepares. There is no point in restricting anar or palak or anything like that. If we are not consuming it in that amounts that it will cause iron overload. So normal diet, Once a month, if you take an hour of something, that does not matter at all. Like you said, iron syrups will not be given, but that's logic. No, anyway, you're not advising syrup iron in this. So in this case, the mother is a thalassemia trait, right? So her hemoglobin comes as 7 grams. So her doctor advises iron tablet. Do you agree that is it a correct decision? My question is, can a thalassemia trait patient take iron, or do you want to restrict iron syrups or tablets for those trait patients also, trait persons also? They're not patients, they are normal people.
We can advise the mother to take iron tablets.
So iron deficiency anemia can coexist with beta thalassemia trait. So if you are severely anemic, and even if you are a trait, you can still give iron for that. Lot of trait people who are diagnosed as trait don't take iron in their meals because they have read in online on Google, they have found out that there is something to do with iron. No, so a lot of people try and restrict. That is a wrong thing. You don't have to restrict any diet either for major or for trait. Okay. And finally, the family is asking you, doctor, what can I do to get this disease out? How can I cure my child? So what will you counsel?
Allogenic stem cell transplantation is the whole could be done for this patient if at all they want to get rid of the disease.
So you mentioned there is another sibling, right? So
yes.
Has the baby been tested? The other sibling has that?
Yes, he has been tested and he is also a carrier.
Tested as a donor for this child. Has the child been tested for that?
No, he has not yet been tested as a donor for this child.
So this child is 7 years old. Do you think if financial issues are not there, do you think he should be tested now, or is it now transplant is not possible?
Ma'am, transplant is possible, but for this particular patient, ma'am, they are not opting for due to financial constraints only. But patient can be transplanted, and the other sibling should be screened.
Other sibling should be HLA type. Screening is thalassemia.
Should be HLA type, yes.
So this child should undergo HLA typing. All thalassemics should undergo HLA typing with their siblings, and ideally counsel for transplant. Nowadays, financial issues are not a reason at all because government supports transplants. Okay. So government gives up to 10-15 lakhs of rupees for donor as in a sibling donor or match transplants. So you should get it done and get them if they opt for it, then definitely transplant should be counseled, because a lot of people have fears in their mind that there will be something will happen to the donor and things like that. So that you have to allay their anxiety, saying that the donor will be perfectly okay. And if there is a match, definitely opt for transplant. That's all from my side. Preetham?
Just a last question, just for fun. So you have discussed quite a bit of flip side of ferritin as a marker of iron overload. Huh? We discussed that it can increase in infection, inflammation, in hepatitis, etc., etc. But still, ferritin is the most commonly used marker for iron overload. So me, being let's say as an advocate for ferritin, what do you think is is there any worth of doing serum ferritin on a periodically in children with thalassemia? There are so many flip side and flaws about ferritin. It can get altered infection, inflammation, hepatitis, is that. We know that it doesn't correlate often with the extent of organ injury and organ accumulation of iron. Then where is the worth of doing serial serum ferritin in children with thalassemia?
So worth is only just that it is cost effective. Nothing more than that, because cardiac MRI or liver tests, it would be costly for the patient.
Right, so it is cheaper. I do understand. You said it is much cheaper and it's easily available at the point of care as compared to MRI. But does it provide you any information, or you are doing just for the sake of it because it is cheap?
No, of course, it does give information about the iron that is present in the.
So what's that? Can you give be more objective and precise about what exactly serum ferritin gives you, particularly when you do it on a serially observing the trend? So the most important information that you get on doing serially serum ferritin is a persistently suppressed serum ferritin over a long period of time gives you reassurance that that person has a significantly low risk of developing cardiac morbidity secondary to iron. That is a very important information that gives you, right? And second thing, when your serum ferritin is steadily decreasing on some chelation therapy, it's a good indicator that your chelation therapy is working. If it is remaining static, or despite giving chelation slowly increasing, that doesn't mean that your chelation is not working. But on chelation, if it is steadily decreasing, however slowly it may be, it gives you again an indirect reassurance that your chelation is indeed working, right? So it reassures you about the effectiveness of your chelation therapy, and also a persistently suppressed serum ferritin over a prolonged period of time gives you a reassurance that the patient is not at a risk of significant iron accumulation associated cardiac injury. So these are very important information that ferritin gives us, and obviously, as you told, they're very easily available at the point of care and quite cheap. I think you presented really well and gave the answers of these difficult viva questions also really well. You're really prepared well, I guess. Thank you.
So, thank you both the experts. Actually, I learned a lot from this case also. It's always a learning process whenever you get a PG discussion and many of the things, new things you get to learn from the experts. Today, I enjoyed the step-by-step questions of Neeta ma'am and some googly and twisted question by Preetham sir also. I thank both of the experts. Jaldi has prepared very well. I must congratulate her that being to present it on the online platform is always a challenge, and to be prepared such nicely is definitely a good preparation. I thank one again for both the experts being here. eGurukul is there for at every Saturday 5 to 7, and we are trying to help our PGs. So once again, thank you, ma'am. Thank you, sir.
Thank you, Dr. Nehal. Thank you, Dr. Prashant, Dr. Parikh, for this invitation. We really enjoyed the discussion and very well discussed, Dr. Jalati.
Thank you, ma'am.
Thank you everyone for the opportunity. Even I learned a lot of things from Neeta ma'am and the discussion. It was really fruitful even for me, and I really thoroughly enjoyed the last 2 hours. Thank you for the invitation and involving me. Bye.
Thank you. So we are ending here.
All right,
so you
ma'am. Thank
can
you so
stop
much.
live streaming. Yeah.